welcome to this month's episode of Picture of Health. I'm your host, Lauren Lengyel. Joint replacement surgery is a procedure in which a joint or parts of a joint is removed and replaced with a prosthetic device. Lakeland Regional Health is recognized throughout the state of Florida for its expertise and capabilities in joint replacement surgery. And today, we are lucky enough to have 3 staff members here in studio to guide us through what patients should know before, during, and after the procedure. I'd like to welcome Lori Carls, Dr. Richard Crank, and Clarissa Watkins to the show. Thank you for being here today.
Thank you.
Thanks for having us.
I'm really glad to see everyone's got their joint face on, and we're gonna, talk some replacement stuff. We'll start with you, Lori, and if we could just go through and discuss your roles in the joint replacement therapy and the entire, before, during, and after.
Okay. I'm a physical therapist. I work at the outpatient facility at Grasslands for Lakeland Regional, and we work with patients before and after joint replacement, preparing them movement-wise, get muscle strength, gait patterns down, and then afterwards restoring them to function so they can get back to life.
And your actual title is?
Physical therapist.
See, I knew you were a big deal. And Dr. Crank, obviously, you've got the whole doctor thing going for you. Tell me a little bit about your role as you see it as a doctor.
Sure. So I'm fellowship trained in joint reconstruction surgery. I spent an extra year of my life dedicated to fixing people's hip and knee replacements and complications with that. The biggest challenge is determining which patients are the right candidate for that surgery. It's a long process. It's a scary process. People know when they're ready. It's not your heart. If we don't do this, you're going to die. It's your joint. You want to get back to the ability to walk, to play with your grandkids or your children, and be as normal of a life as that you're used to, understanding that there are limitations. It's metal and plastic. It's not God's hip. It's never going to be exactly the same it was. My best example that I like to give people is we have yet to build a car that we don't have to change a brake pad. If you don't change the brake pad, the car doesn't do well. So these are the limitations. The larger the car, the faster the brake wears out. So the biggest key is education and determining when and right for you.
And Ms. Clarissa, what is it that you do at Lakeland Regional Health?
Okay. I'm a registered nurse on our orthopedic unit, and what I do is I help assist those patients and help take care of the patients that have had those total joints. In addition, I also assist in teaching our total joint class to help prepare those patients for coming in for their total joints.
So Dr. Crank, tell me how you spoke a little bit about how we figure out who is a candidate for joint replacement. What happens that someone finds their way to you?
So the typical route that people figure out, they've seen their primary doctor, they've been evaluated, they've had some x-rays, they've been dealing with joint pain, usually deep muscle aching bone type pain at night, sometimes better in the morning, later in the afternoon. And after they've dealt with this for a period of time and gone through a gamut of conservative treatments, then they typically are referred to me for further options and to truly understand where they're at in their life.
Is there a range of age that you typically see joint patients?
You would think that would be concentrated more in the later part of our life, usually after 60. Unfortunately, there's many different forms of arthritis. Some can be very young and some can be very old. I've done joint replacement on people that are 17 years old. I've done joint replacement on people that are 93. Every person and every body is different, and so you have to determine when and what is right for them.
Okay, so once we've determined this person is a perfect candidate, they're a prime candidate, then one of you two ladies comes in with education to prepare them for this type of surgery. So who takes over first?
Sometimes patients are sent to physical therapy before surgery. Maybe they don't have enough motion in their joint, they have muscle weakness. We try to get them prepared for the surgery so that their outcome will be better after surgery. So sometimes they see us first. We try to do some education as far as what's going to be expected afterwards. What are they going to have to do in their home? What are they going to have to do in therapy? How are they going to get back to life?
On its face, it makes sense to me that you would do therapy before surgery, but what is the rationale for that? Is it the tissue becomes stronger and there's more blood flow, that kind of thing?
There's a lot of research that supports the fact that if you have good motion, you have strength, you're walking as good as possible before surgery, the outcome and the speed of recovery is much better.
Your predictor of your outcome after surgery is your functional level and health before surgery. The stiffer you are, the weaker you are, the more difficult your recovery and the less likely you're going to get an outcome with successful results. Exercise is good. You're not going to create more damage. The damage is done. All you're doing is strengthening the muscles that are across the joint to allow the joint to be stronger and recover healthier and faster.
And your piece would be on the education side?
On the education side.
Okay.
When we have our class, we want to get the patients ready. We want to make sure that their home is ready for when they come after their surgery and when they go home.
So, what do you mean by get their homes ready? So when let's pretend, I've just had joint surgery. What does my home need to look like when I walk into it?
Okay, we want to make sure that when they go home, we want to make sure that there's enough area for them to ambulate or walk through. We want to make sure that there are no throw rugs because those things are a hazard. And
even when you haven't had joint surgery,
yes,
those things are a hazard.
We want to make sure that any small animals, that those are, not in the way or anything. We want to make sure that their toilets are at a level so that they may need a bedside commode or an over-the-toilet commode to go there so that they're not down too low when they're using the bathroom. Those are some of the things, making sure.
And so what else comes into play with the class? Is there any, explaining of how the doctor's actually going to do the surgery?
No, we usually don't talk about the things that will happen in surgery because usually the doctor goes over those things with them. We usually talk about the things leading up to the surgery and then after the surgery.
Gotcha.
Yes.
Okay. So we've got our knowledge, we're doing our physical therapy. I've got an appointment with Dr. Crank. What's the next step? Just show up for surgery?
No. So the next step is when you have your appointment with me, we sit down and we talk.
Okay.
I take x-rays, I look at your x-rays, and I talk to you as a person about what your goals are. If your goals are to continue to run 5Ks, 10Ks, and marathons, you're not ready for a joint replacement. Excuse me. These aren't made for that. They're made to allow people to walk. You can hike, you can bike, you can swim, you can fish, you can play golf, you can do doubles, tennis, volley. But they're not made for running and jumping. They wear out. They're metal and plastic. They'll break. So goals are number one. 2 is health. Are you diabetic? Are you overweight? Do you smoke? Are you anemic? These are all big risk factors that can compromise your outcome. And the most tragic outcome that can occur is infection. And so if you get an infection, it can ruin your life. It can lead to amputation. Therefore, we want you strong, healthy, and understanding your goals and limitations. Once you understand that, then we have the discussion of surgery and which can be appropriate for you.
So it's really addressing those lifestyle changes that, you would expect that your patient would take steps through to changing those things. But so you're saying that if someone has an expectation that they are going to continue their level of activity marathons, 5Ks, etc., that they would not be a candidate
Correct.
for this surgery.
Bo Jackson had 3 hip replacements within 5 years. It's not made for that.
So if someone did, I'm interested, if someone did in fact say, you know, I think I'm going to just deal with the pain and keep running and things like that, the comment that you made earlier is it's not going to get any worse. Does that still hold true?
It does hold true. A lot of times what I tell people is if you really are an avid runner and you really enjoy running, you can do it. You may just have to modify how you do it or where you do it and your intensity of it. You get to a point and you can't do that, then you switch to other things such as swimming, biking, low impact activities. Those you can last a lot longer because a joint replacement is not made to allow you to be competitive. It allows you to have a lifestyle that's moderately pain-free. Not completely pain-free, but moderately pain-free. And
the risk of infection, where's that on the spectrum? What increases those risks? I assume that you wouldn't do a surgery if there was a high risk of infection.
Well, correct. And that's what I think the biggest goal in the campaign of the American Academy of Orthopedic Surgeons right now is educating what we do and who we operate on. Number one, smoking. Smoking is an absolute contraindication to elective joint replacement currently. You must stop for a minimum of 6 weeks. There are institutions in this country that the day of surgery you have to take a breath test.
Oh, wow.
And if you fail that test, your elective surgery will be canceled. Diabetic control is number one as well. So the third thing is obesity. If your body mass index is over 40, it's a contraindication to surgery. So those are the 3 most common risk factors that I find in my practice that delay someone getting their joint replacement, whether they need it or not, and whether they want it. But you have to protect them because that lifetime risk of infection never goes away. It's not just the immediate post-operative period. Their infection can occur from any type of infection they get in their body. I've had people with joint replacements that have been in for more than 10 years get an ear infection, ignore it, it gets in their bloodstream, infects their joint replacement, and then it has to be removed. And I think that's the biggest part of what we do is educating people, not just doing the joint replacement.
It's time for a quick break, but stick around. More information about joint replacement surgery with Lakeland Regional Health coming up next.
Don't wait. Communicate. Make your emergency plan today.
This is a sewer line backup, and yes, it smells. But that's not the worst part. When sewer lines back up, they can cause property, road damage, traffic tie-ups, and send sewage into storm drains where it seeps into our lakes, rivers, and groundwater. Pretty serious stuff. But the real problem isn't here, where the sewer line backs up or breaks. The real problem is somewhere you wouldn't expect. Come on. The backup you just saw was probably years in the making. Average Joes going about their lives, never suspecting that they're part of the problem. And what's the problem? The problem's fog. That's fats, oils, and grease. Fats, like meat trimming, cheese, milk, and other dairy products, as well as shortening and lard. Oils, including cooking oils, olive oil, salad dressings, condiments. And grease, like cooked or melted fat from meat, bacon, sausage, poultry, even gravy. You throw them down the drain. Before you know it, the pipes, they're lousy with it. Sure, maybe you send it down with some hot water, makes it past your pipes, but sooner or later, hits the big stink. Are the pieces of the puzzle starting to fall into place? No, I'm not telling you to lay off dinner for the kids or snacks for the big game. I'm here to help you sniff out the truth. Chill grease in the fridge, then wrap it up and throw it away. Pour oil into a sealable container like a bottle or a jar and toss it away. That goes for food scraps and coffee grounds too. Just keep the fog out of the sink and everything will be Jake. Thanks, dog.
(150/90).
180 over 111.
160/110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it, or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
Welcome back to Picture of Health. In case you're just tuning in, this month we're learning about joint replacement surgery with Richard Crank, Clarissa Watkins, and Lori Carls from Lakeland Regional Health. So we were just talking a little bit about infection and how we want to prevent that and mitigate the risk of that prior to surgery. So tell me a little bit about what happens day of surgery.
So the day of surgery, one of the first things we do to prevent infection is 2 days before we use soaps, and you take a special shower to decolonize your body of normal flora and bacteria that just grow on our skin. Sure. And we usually start that. Then the day of surgery, you meet with the surgical team, the anesthesia team, and they start to discuss your options of what your anesthesia will be and how you'll go through surgery. We use a multimodal approach with anesthesia. We basically give you medicine to help prevent nausea, help prevent anxiety, and help to start blocking your pain that you're going to receive from the surgery before you're even in the operating room. We have special blocks that can be done through our anesthesia department, and spinal anesthesia where you're not fully put to sleep, but you're in a twilight. And it much decreases your risk with the anesthesia. These are all multimodal pain managements that are well proven in studies and very effective to help control pain. The surgery occurs, and then afterward you're in the recovery room. The types of surgery you get, it depends on which joints are replaced, and those are specific to you as a person. There are many different ways to do the surgery, but they are tailored to you. So some will market different approaches, but that may not always be your best option. And if you have questions, I encourage multiple opinions before you pick a surgeon, because it is one of the most scary but yet exciting opportunities to change your life.
I do want to back up for just a second. And what are some of the things that keep people from committing to this surgery, from saying, hey, I want to go ahead and I want to go through with this, aside from limitations they may have?
Most people are just afraid. They know someone that had a joint replacement that went bad. It was infected, it broke, it didn't give them the relief they necessarily had. And so what I try to do is reassure people they'll know when they're ready. Everything else they've tried doesn't work. They can't do what they want to do, and they're tired of dealing with it. And when they're at that point, they know in their heart they're ready. They're ready. And if they're unsure, I always recommend to get a second opinion from someone else. There's no harm in that. The more comfortable you are and the more prepared you are with your family, the better your outcome will be.
And what I've gathered in all of you is there's this great wraparound support that happens before surgery, during surgery, and after surgery. So after the patient's out of surgery, what's one of the first things that they can expect?
So immediately in the recovery room, their number one goal is their pain control. Depending on how their anesthesia was and the type they chose will determine how that occurs. The goal is the faster you're up and walking, the faster you're going to recover. It used to be that we'd keep you in bed for 2 or 3 days, but now we try to get you walking within 2 or 3 hours of the surgery. So we have found that the faster you move, the faster you recover, and that's where the floor takes over.
which is important. The main thing is making sure their pain is under control. And again, it's what Dr. Crank said, getting them moving.
I would imagine that would be kind of difficult for some people if you say, okay, now you're going to get up out of bed.
Yes. Usually they're kind of apprehensive because I just had my knee done, or I just had
You just
my
cut my
hip
bone
done.
off.
Right.
Correct.
But you also have some of those who are anxious or they're excited about getting up. But we do get them up out of that bed, into the chair, and have them, that also helps with preventing blood clots, getting up sooner after surgery and moving. So they're getting up, sitting in a chair an hour, hour and a half, and that really helps them.
How long after surgery is physical therapy occurring?
They get physical therapy in the hospital.
Okay.
Physical therapists come in and assist with helping them use a walker, which most of them need right after surgery. We usually try to teach them some exercises before and try to get them doing those exercises for mobility, for strength, as soon after the surgery as possible. So they have therapy in the hospital, again, probably within hours after surgery.
Yes.
And then you help everyone to have everything. I assume they talk to you again. You get all the information that they need. You've already spoken to them about getting their homes in order.
Yes.
For when they return.
Mm-hmm.
What's the other protocol, the parts of the protocol I may be leaving out?
For when they go home?
Mm-hmm.
Oh, the social workers talk with the patients. But before that, at the total joint class, they're also giving the patients their options that they have.
And the total joint class occurs before surgery?
Before
Okay.
surgery. Before surgery.
Okay.
And a good thing is not to come the day before surgery, but also to come maybe a month before the surgery, because the longer time that you have between to get ready is, I think, is important. But the patients usually can either go home with outpatient physical therapy, they can go home with home physical therapy, or they can go to a rehab facility where they're there and getting extra physical therapy and care. And usually for maybe 10 days, 2 weeks, something like that.
I would imagine that would save some marriages. I know a friend who had knee replacement surgery, and her spouse would not have done well with running around and stuff like that. So,
Yes.
Okay. So, given those options, is there one that is the best? Is a rehab facility normally your recommendation, or does it really just depend on the patient?
Well, I think it depends on each patient's situation. If you really have no friends or family around that can support you for the next really 5 to 7 days is kind of the most difficult transition point, that's probably your best option. Because the worst case scenario, you wouldn't want to go home and fall and break something. That can really change your outcome. But 90% of people go home. You know, Dorothy said it best, there's no place like home. And it can be, it stands true. You're in your own home, you're in your own environment, and you're with your support group that you have. And a lot of times that's impeccable for your recovery.
And how much of that support system that plays almost the same kind of role as exercise in your preparation?
I would say to have a support role is probably the #1 thing that you can do, and that's why having them attend, having one person, a coach, attend with you at the joint class, so that's an extra ear hearing, plus that's your support during that recovery. So if you can have a coach for those first 5 days, you'll be so happy.
Oh, that's awesome. And then you get to go in the home, or do they come to you?
That also depends. If they're able to get out of their home, again, getting up and moving is very important. So the sooner they can, if they're able to get out to outpatient therapy, then they'll come and see us. Or home health can go in and do therapy in the home as an alternative to going to a rehab facility, or even afterwards if they're still struggling, home therapy is an option as well.
So what types of exercises and things like that can a patient expect to do post-op?
We have a series, we give a handout of exercises, and most of them are aimed at flexibility, getting muscles to stretch and do the movement that's required for normal activity, and then do some strengthening. During the degenerative process of a joint, a lot of times the muscles shorten. You get in positions of preference, but those aren't necessarily normal positions, so they need to stretch, and then they need to strengthen. They tend to get less mobile as the joint gets worse and worse, so you also look at endurance. Are they able to maintain adequate breathing while they're doing activity? So if they're doing those things beforehand, then when we start doing them again afterwards, they're much more comfortable and they know what to expect. So they do very simple exercises such as leg raises or standing and bending their knee, going up and down on their toes, some fairly simple exercises. And again, they're able to do those right up to the day of surgery, and again immediately afterwards. Those are the exercises we give them.
You know, I have a friend that went through the thing, and watching her go through it, it's very doable, but there are some parts that you can tell there's some pain. So nothing worth doing.
Usually the first 3 weeks are the most difficult. Once you get through the first 3 weeks, the swelling starts to come down and people start to feel a lot better. By 3 months, most people are happy. It takes a full year to get all of your strength back, but just the first 3 weeks tend to be the toughest.
Well, as a physical therapist, I'd like to say that when people talk about replacements that have failed, if the surgeon does a great job, which we expect, there's been no complications with infection. The other big item that can cause a failure, not of the joint, but of the result, is that they don't do their therapy. I always tell patients, when your brain says don't move, really the most important thing to do is to move. So just letting them know that there are some things they're going to have to do that are going to be uncomfortable, but if they don't do them, the outcome is not a good outcome. So we want them to have the best function, enjoy their lives, have the highest quality of life possible.
That's absolutely true.
So you've got metal in this piece that you're replacing, either in the hip or the knee. What happens when you go through a metal detector?
So there's different stories. I've heard many. That we used to hand out cards. That we stopped doing that because every airport's different. So I tell people, before you walk through the scanners, tell them that you've had a joint replacement, you have metal in your body, because every airport is doing things how they handle it differently. I've had people walk through scanners, I've had them not walk through scanners, I've had them be wanded down, I've had them one that had to show a scar. So everything is different, you know, and I'd say just try to remember that you got it, because sometimes in a few years you'll forget that you have it.
And that's the goal. Well, thank you all so much for being here, and you know, I think you've really helped provide a holistic view of how knee replacement takes place at Lakeland Regional Health, and probably how it should take place other places. So thank you.
Thank you.
Okay. Unfortunately, that's all the time we have for today. If you'd like to watch this episode again, you can catch a replay on Tuesdays, Thursdays, and Saturdays at 2 or 8 a.m. and p.m. or find us on Polk Government YouTube page. I'm your host, Lauren Lengyel. I'll see you next month for another Picture of Health.